Welcome to the Neuromodulation podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Welcome to this episode of the Neuromodulation podcast, brought to you by the International Neuromodulation Society. Today, I'm delighted to introduce Dr. Dalia Elmofty, Associate Professor, Associate Program Director, Pain Fellowship, University of Chicago, Chair, Education Track on Pain Medicine for the American Society of Anesthesiologists, Chair of the Newsletter Committee, and Chair of Women in Regional Anesthesia and Pain Medicine for the American Society of Regional Anesthesia and Pain Medicine, President-elect for the Midwest Pain Society, Board Member for Women in Neuromodulation at NANS, the North American Neuromodulation Society, and on the Newsletter Committee for NANS. Welcome, Dr. Elmofty.
Thank you.
We're excited to have you here today to talk about your expertise in neuromodulation for neuropathic pain. Could you start by sharing your background and expertise in the field of neuromodulation and neuropathic pain?
My initial specialty training is in anesthesiology, and I'm board certified in pain medicine. I've been practicing for about 14 years now. I started from fellowship and went into academic practice at University of Chicago. During my training, there was a heavy focus on neuromodulation. I was fortunate enough to gain that experience and take it with me as I advanced my career. So that's how my career began, focusing on different neuromodulation techniques that can be utilized for different types of pain syndromes.
That's really interesting that you mentioned that during your training that there was a heavy emphasis on neuromodulation, because I've not heard that before. What constituted to that for your specific case?
The training program itself was very well established, using multiple forms of neuromodulation, not just spinal cord stimulation, but intrathecal drug delivery system. And obviously that was one of the things that attracted me to that field, or to that particular training, because there are many things that we can offer patients, not just pharmacological interventions, but also non-pharmacological interventions. So it was quite a multidisciplinary fellowship training, so I was very lucky to have that.
Yes, certainly. And helping our listeners understand that there's so much more to the world of anesthesia and interventional pain management. Neuropathic pain can be particularly challenging to manage. How does neuromodulation offer a unique approach to the treatment of neuropathic pain?
A lot of our pain syndromes and our pain etiology have been managed using pharmacological methods. Neuropathic pain, if you understand the pain processing behind it, it's basically a disarray in pain processing. So it naturally promotes itself to neuromodulation. And what I mean by that, yes, there's pharmacological methods and non-pharmacological methods. Some of the non-pharmacological methods can be invasive or non-invasive. So again, as we use the term neuromodulation, we can talk about spinal cord stimulation, we can talk about intrathecal drug delivery system, we can talk about some other advanced forms of neuromodulation, but I think what we'll probably focus a little bit more is on spinal cord stimulation. So why does it provide a unique advantage? Is unfortunately a lot of the target therapy that's currently available right now for neuropathic pain in terms of pharmacological methods. How can I describe it? It gives an indiscriminate treatment path, a very broad treatment path, and when that occurs, there's more potential for side effects and other neurological deficits that can occur. But when we're using spinal cord stimulation or neuromodulation in the form of spinal cord stimulation for neuropathic pain, we are able to target certain areas, certain cell lines that are more specific to the pathway in neuropathic pain, therefore minimizing some of the side effect profiles that can be found with some other pharmacological methods. I'm not saying that with spinal cord stimulation it totally limits all side effects. There's always side effects and risks associated with any type of procedure that we perform, but in regards to how can I say, pharmacological side effects, it can definitely limit that.
Could you speak to some of the success stories from some of your patients in activities of daily living and quality of life?
I can refer to some of the conventional indications for patients who've utilized neuromodulation, but focus a little bit on what might be considered some of the non-conventional. Patients who have multiple sclerosis. These patients definitely present with a neuropathic component of pain, along with other neurological disorders. With MS, basically what happens is there's a dysfunction in myelin formation. The immune system attacks myelin formation. And when that occurs, obviously that affects critical things like impulse transmission from the brain to peripheral organs. And these patients, unfortunately, will suffer from an array of symptoms. A big portion of it is pain. So about 85% of patients who have multiple sclerosis will also report neuropathic types pain, anywhere from paresthesias to burning sensations. 90% of them will present with motor deficits, and most forms of that would be spasticity, sometimes tremors as well. And these symptoms can actually potentially be treated or managed using neuromodulation, such as spinal cord stimulation. So we're controlling symptoms or MS symptoms, but we're also hopefully helping with recovery of function. So I do have one particular patient that comes to mind. She was 30 years old, and she had been suffering from progressive secondary MS for the past 8 years. Basically, her main symptoms was pain going down her upper extremity, burning type pain, electric shooting type pain. With reduced activity, she had to actually leave her job because she wasn't able to do certain functionalities. We had tried a lot of non-pharmacological methods, physical therapy, occupational therapy, transelectric nerve stimulation, medications, anticonvulsants, antidepressants, the typical treatment pathway for patients who suffer from neuropathic pain from MS. And then we decided to trial spinal cord stimulation. One of the things that we're quite lucky is that with the advancing technology that's occurring with spinal cord stimulation, we were actually able to implant the device for her. Again, one of the biggest reasons we don't implant devices in certain patients is because in some devices it can restrict certain types of imaging, meaning MRI imaging. But again, with advanced technology, most of our manufacturers, the devices are now MRI compatible. To cut to the story, she ended up having the device. We did the trial. She had about 50% improvement in her pain and improved functionality. We ended up implanting the device, and at that 6-month follow-up, she was back to work. She had 50% reduction in pain. She really felt that things were taking a turn. She was happier. She was functioning. She got to go back to work. That obviously left a pretty big impact for me, being able to see her to return to the activities that she enjoyed.
Absolutely. And for people who've not dealt with chronic pain for 8 months is something to be said, even psychologically, but 8 years, if one can imagine just the difference that the spinal cord stimulation made in her life.
Definitely has an impact on all aspects of quality of life. Yeah, so far she's doing well.
That's wonderful. Can you share a little bit about how neuromodulation techniques play a crucial role in the management of chronic pain, especially in the case opioid epidemic may not be the optimal choice?
Yeah. Again, in the past few years, there has been a lot of discussion about opioids and the use of opioids for chronic pain. And in general, when we talk about neuropathic pain states, we have algorithm of treatment approach. And opioids is actually not in the first or the second line treatment option. If you go from an evidence-based approach, it isn't necessarily something that we would recommend because it really doesn't neuromodulate. When we understand neuropathic pain, again, it's a disarray. We know that there are pain processing signals that aren't functioning appropriately. So we need to utilize our therapy that's going to help re-educate these signals or get them to function appropriately. And opioids, I'm not saying that they aren't beneficial in pain. There's certain types of pain where it's more beneficial versus other types of pain. We know in a lot of our chronic pain states, it can actually harm our patients. We understand the phenomena of opioid-induced tolerance with escalating doses as a result of the tolerance and the increased side effect profile that can occur because of that. But at the same time, we understand that opiates do create a phenomenon known as opioid-induced hyperalgesia, which puts patients in another type of quote-unquote neuropathic pain state. So we gave them, if we introduce opioids, not only are we dealing now with their underlying disease pathology, but now we are also dealing with a new phenomena that we introduced. So being able to have a modality that won't have that type of side effect is very crucial. Again, neuromodulation, it's non-pharmacological. All the literature that's out there regarding agents that are available for neuropathic pain only show a 30% efficacy, meaning patients, if they get to the 30% reduction in pain, we'd be happy with that. We don't see the 50, 70, or 80% reduction. Where neuromodulation, we potentially do see that. Other than side effect profile, there is improved efficacy using neuromodulation. And again, if we can manage pain with things that are less harmful and more along the pathophysiological means in reversing pain states, obviously that is more beneficial for our patients in the long run than using something that sometimes can be considered as masking the pain, referring to opioids.
Right, and getting to the root of
Correct.
the pain. And have you had any patients who just outright don't want to take the pills?
Increasing awareness and education. Some patients are actually very fearful of opioids. And patients who have history of substance use disorders or family members who have substance use disorders, yes, they are fearful of opioids. They do want their pain to be treated, but at the same time, they want an option that has the least side effect profile. That's definitely a benefit. And also in patients who not necessarily are severely cognitively impaired, but have that tendency, our older population, this also could be something that can definitely help benefit them without the side effects of opioids.
So what I hear you saying is that opioids certainly have their place,
Correct.
but it's under a trained professional as yourself who can really explain to the patient their options and the efficacy of what those might be.
Correct.
Yeah, that's super important. The field of neuromodulation continues to evolve with technological advancements. What are some of the latest interventions and emerging technologies that are reshaping the landscape of neuromodulation for neuropathic pain specifically? And how do these innovations hold the potential to further improve patient outcomes?
So again, traditionally, when we think of spinal cord stimulation, it was basically to target dorsal column, right? But through evolving research, we now understand that there are other cell lines and targets that can be involved in the pain modulation and waveforms, and they can enhance neuromodulation in general. We've come to know the dorsal root ganglion is a very important target and sometimes acts as what we know as the gatekeeper, signal controller. And we know that there are so many different waveforms than what was initially introduced back in the 1960s, right? That tonic type waveform that can also help patients. Waveforms like burst stimulation and 10 kilohertz. We also have a better understanding on just in general where neuromodulation occurs, whether it occurs at the periphery, within the spinal cord, in more supraspinal structures. And that being said, we target these structures. I can give you some examples. We understand that glial cells play a very big role in neuropathic pain and modulating certain neuropathic pain states. And we understand that if we target glial cells using varying signals, we can make them more effective, correct? And that can in itself help with neuropathic pain. And there's different waveforms that have been introduced to help with this. That typical waveform that we're quite familiar with that's been introduced is DTM, otherwise known as differential targeted multiplexed programs. There's also new waveforms that are coming out, like multiphasic stimulation. With this waveform, it basically provides not a single therapeutic phase within an electrode group, but multiple phases continuously and can occur throughout the spinal cord. Other things, we know that we have low-frequency stimulation, subperception, that promotes inhibitory signals at the dorsal column, and this can block our wide dynamic range neurons. And we understand that this actually occurs quite quickly, and that's how it got its name, otherwise known as FAST, meaning fast-acting subperception therapies. So other waveforms that are being introduced, closed loop with evoked potential, where now the device itself can pick up on sensing and readjust based on patients' neural needs, in a sense. So again, the evolution of neuromodulation, and we are relatively a young field. It's only been around for, you can say, decades, and we continue to advance in our knowledge. And with that advancement, we're learning more about the nervous system, how it processes. We're learning more about what we can target, particularly with neuromodulation, specific targets within the pathway. And again, when you think about pain processing, it's a cascade of events. If we stop one event, hopefully it can stop further events down the road and the chronification of pain. So yeah, neuromodulation definitely has this huge potential in not just pain, but again, restoration of function and many aspects.
It's interesting, the connection with you being a leader in women in neuromodulation. My understanding with the glial cells, that those were once just thought of as not being important until a group of women further looked into them. And now you're saying really it's at the heart of some of these pain syndromes.
And targets for therapy. Yep. Research is very vital to our field, and incorporating it. We all have very busy lives, clinical practice, life outside of work, but to benefit our patients, it's really important that we all participate in some aspect of it to promote our field.
Yeah, it's critically important. Neuromodulation, while promising, may present challenges of its own. What are some of the challenges or considerations that clinicians and researchers should keep in mind when implementing neuromodulation in pain management?
We were talking earlier about the traditional spinal cord stimulation using tonic therapy. There's been so many advances in the waveform. And because there's been so many advances in the waveform, we do have an understanding on certain aspects of neuromodulation, but we need to better those understandings. These new platforms are phenomenal, but we need to understand how to use these platforms for specific neuropathic phenotypes, right? It's not a one-size-fits-all model. Certain neuropathic conditions have underlying pathophysiology that we need to understand better, and then utilize neuromodulation at different target sites to treat those. Again, it's an evolving field. It does take time. I definitely think we're getting closer. The fact that we understand that there's certain cell lines and targets that we can utilize to neuromodulate. I think the next step is identifying these neuropathic pain states and the pathophysiology, and where exactly is that key area that we should target with neuromodulation. So that's definitely one of the challenges that we have right now, and hopefully one that we will continue to resolve. Again, we need to understand more about these waveforms and the concept of combining waveforms, right? We have all these waveforms. What will happen if I use this one with this one or this one with that one? It's just an evolving field and just so much more to learn about it.
But that's part of what makes it exciting, right?
Yes, definitely.
Looking to the future, what are your expectations and aspirations for the role of opioids, having neuromodulation addressing the epidemic and improving pain management practices?
Again, if you think of the reason we got into the opioid epidemic, it's because, again, we are very limited in treatment options that we have for patients, right? Historically, opioids have been considered, again, the only management available to treat a lot of painful disease states. Again, we're very limited on some of the multimodal therapies that we have. We only have a very small class of pharmacological neuromodulating agents that are available to us. Hopefully in the future we'll have more pharmacological neuromodulation agents, but until that, again, neuromodulation, and again, not just spinal cord stimulation, there are other things. Emerging literature about transmagnetic stimulation. There's emerging literature about brain cortical interface, which is really phenomenal. And basically what that is, electrodes are placed in certain areas, usually external electrodes, that can help a paralyzed patient move their arm, or help a patient that doesn't have sensation, meaning visual, maybe be able to see or maybe be able to speak. So again, with the advancing technology, I definitely feel that hopefully we will not have to rely as much on opioids in regards to certain painful disease states, and that there would be other options available to patients. And again, I don't want to give opioids a bad reputation. Like we talked about earlier, they are definitely valid in certain conditions for a certain period of time, but we also know a lot of the harmful effects of it. When we all became physicians, we took that Hippocratic oath of basically do no harm to the patient. So when we choose our treatment agents, we have to make sure that we're providing benefit versus risk. And that goes for everything, whether it's neuromodulation or pharmacological treatment options.
That's an excellent point. For healthcare professionals and clinicians considering the integration of neuromodulation into their practice, what advice or insights would you offer to help them to get started and make informed decisions? And what guidance or insights do you offer to residents and medical students, given you mentioned in your practice that there is a strong emphasis regarding the evolving landscape of neuromodulation and its potential to transform pain management practices?
Something that I tell my children all the time, it's not my words, but Gandhi, he said, live as you were to die tomorrow, but learn as you were to live forever, right? So that being said, we need to understand more about the pathophysiology of neuropathic pain, right? Like I mentioned before, one size does not fit all. We have to phenotype it. And once we do that, understanding more about neuromodulation, right? As you're starting your practice, understand the fundamentals of it, understand the spine anatomy, understand areas of modulation, because once you do that, hopefully you'll be able to identify which therapy will best target your patient for the type of pain that they have. So that's definitely something that I try to incorporate on my residents, my fellows, even the medical students that are rotating with us that might be interested in pursuing a career in pain. That's very important. And like I said, there are so many treatment options available now in neuromodulations, a lot of manufacturers, a lot of industry. Not every device is going to work for every patient. Again, now with the evolution, more and more devices are becoming MRI compatible, which is a great thing because there are some patients that have more comorbidities that need frequent MRIs, and obviously we can't offer that therapy to them. So again, understanding the basics is really important before you venture into a career where you incorporate neuromodulation.
Absolutely. Are there specific resources or organizations that clinicians can turn to for guidance and support when incorporating neuromodulation in pain management?
So there is an abundance of societies, whether it's at the regional, the national, or international level, that offer several educational seminars. There's so many journal articles that are published. There are so many book chapters available. And even not that, you can shadow with a colleague that is a neuromodulator, do an observership. So many availabilities. And I'm right here at NANS, North American Neuromodulation Society, that's devoted a lot of its research efforts into all different types of neuromodulation. So there's so much support available. It just takes the initiative for you to get involved and participate.
Reach out
And reach out. And you brought up a really good point about the global networking that's occurring. That is something that's just recently, I shouldn't say recently, but has been occurring in the past few years. And that's wonderful to see. It's not just in the United States, our sister societies that are international. It's really quite an exciting time for neuromodulation.
Absolutely. And they have the congresses and conventions just as we do. With the INS, we rotate throughout different countries, but each region has their
own society.
Yeah. And I think that education is critically important for a variety of different specialties.
And the networking amongst researchers that are in different countries. It really, again, I feel it's going to open up the field. It's going to open up the research, right? Both the basic and clinical research. So it's a good time for us.
Yes, absolutely. What key takeaways or final messages would you like to leave with our listeners from this discussion on neuropathic pain management?
Be passionate, be compassionate, be eager to learn new things. Take on the challenge. It's really important. We're not always going to see very straightforward patients. It's not going to be bread and butter. And when a complicated patient comes your way, having a broad array of knowledge of different treatment options that can be utilized for them is going to help you help them. So I think it's really important. Don't stay in your little circle of just doing epidural steroid injections for somebody that comes that has back pain radiating down their legs. There are other advanced interventions that might benefit these patients. Be open to them, look into them, research them. Like I said, be proctored, go learn how to do it. This is what our patients need. They need us to continue our educational efforts, our research efforts, so that we can help improve their outcomes.
That's such a beautiful way to close, specifically at this convention, being that you know exactly what I'm going to say is that the theme is patients first.
Correct. That is what medicine is all about. Again, that's why many of us went into the field of medicine. It's to devote our career to improving the care of our patients.
Absolutely. Thank you, Dr. Elmofty, for joining us today. Neuropathic pain is actually one of our top searched terms at the INS on our website, and this is going to be such a valuable conversation for our audience.
Thank you for inviting me. I appreciate it. Thank you.